the nutrition, there are every time you will get at least 3 to 4 questions in a different way. So you have to know the ESPN guideline and the nutrition, also the refeeding syndrome. So every alternative year there is a same refeeding question coming in a different way. So before that, you should know there are some definition. What is isocaloric diet? Is the energy administered around the defined target, and the preparation is 1:1, 1 calorie in a 1 ml. What is hypocaloric or underfeeding? Is the energy administered below 70% of the defined target. So suppose your calorie requirement in 1600 and you are giving 70%, that is hypocaloric or underfeeding. Or your calorie requirement in 1600. Hypocaloric, then trophic feeding is a minimal administration of the nutrition having beneficial effects such as preservative interstitial epithelium. Basically, you are giving small amount of feeding to preserve the interstitial lining and preserving the epithelial tight cell junction to prevent bacterial translocation. Here you are not targeting the calorie, but you are giving some amount of feeding. Usually we give trophic feeding in the early phase, very malnourished patient, very cachectic patient. So if you give the isocaloric or you are giving the hypocaloric, they might have the refeeding syndrome. So to prevent this refeeding syndrome, you can continue. Or in a patient with a inotropic support, lot of inotropic support, you are not able to give enteral feeding because of there is a risk of gut ischemia, then you can go for the trophic feeding. And overfeeding is energy administration more than 110% is overfeeding. And low protein diet is we will discuss later on. We will have the ESPN guideline for different recommendation, and you have to read the recommendation because there will be a type or K type. A type question sometime come from nutrition, and the K type definitely you will get 2-3 recommendation where you have to put your answer true or false. So why nutrition is important? Because 50% of our patient, those critically ill admitted in the ICU, they are malnourished. And if there is a malnourism is there, so there is a chance of infection or recurrent infection is high because their immunity mechanism bit altered when there is a chronic malnutrition in an ICU patient. And so it increases the day of mechanical ventilation, it increases the length of stay in the in your ICU. So first recommendation, medical nutrition and therapy is considered for all patients staying in the ICU mainly more than 48 hours. So you have to start your nutrition either enteral or parenteral within the 48 hours of ICU admission. So how will you calculate the energy requirement? So there are recommendation or the enteral route is preferred than your parenteral. Now the next question is coming, how will you calculate the energy requirement? So it is very important how much feed you will give, how will you calculate? There are a lot of equation is there. The complicated equation is Harris-Benedict, the basal energy requirement. But in simple way, remember 25 to 30 kilocalorie per kg per day is the energy requirement. And when you are initiating, is ideally you should initiate with a hypocaloric. There are lot of paper has coming where it is recommending ki you go in a not in a isocaloric, better you go for a hypocaloric diet. So avoid overfeeding. Early full enteral or parenteral should be used in critically ill patient, but shall be prescribed within 3 to 7 days. In parenteral nutrition, initially it was recommended that you should start after 7 days or after 6 days of NPO. But the newer guideline, this is the ESPN guideline, whatever I'm quoting here in my slide. So it is recommended within 3 to 7 days you have to start. So now next confusion is whether continuous feeding you will give or in a bolus feeding. So the continuous feeding is recommended in ESPN guideline. There are certain advantage over the continuous feeding. So advantage is it reduces the nursing work, and also it reduces the contamination, and it will give continuous feeding, so the glucose level in the blood is maintained. But in contrary, if you give bolus feeding like 100 ml second hourly or 200 ml second hourly, it happens, it reduces the cost, because for continuous infusion you need a special continuous infusion pump, or you need the bag, kangaroo bag is calling, for the continuous feeding. But in bolus, it increase the nursing manpower, also chances of contamination. And in bolus feeding, there are some institute prefer bolus feeding. Bolus feeding, if you give, it will the P. pyloric things can be given in the bolus. It is ideal, but if you give the post pyloric feeding, then continuous is the better. So now next recommendation is the gastric access should be used as a standard approach for initial enteral feeding. So gastric approach is always better, and patient with a gastric feeding intolerance not solved in prokinetic agent, prophylactic feeding should be used, post pyloric feeding should be used. So when you will say it is a gastric failure, so enteral feeding failure, so if your the aspiration is 100%, then you can say in the you can say this is a gastric failure, but you can't stop enteral feeding. You should start giving the prokinetic as European guideline. When the which prokinetic you will use, though in the Asian country, in the India, we use the metoclopramide, but for MCQ, you have to click on the erythromycin, because they use the prokinetic agent erythromycin IV. Or second line is your metoclopramide. So remember this thing, this can become in the A type or K type question. So when you will say failure after giving prokinetic agent, then also the aspiration is coming, then it is called aspiration is 100%, then you can say it is a enteral failure. Or management is that you reduce 50% of the feeding and use use prokinetic agent, and then let's see if the aspiration amount is reduced, then you continue enteral feeding unless it is absolutely contraindicated. So recommended 13 is in critically ill patient with gastric feeding intolerance, intravenous erythromycin should be used first line of prokinetic therapy. That is their recommendation. Though we in India, we use metoclopramide as the first line of drug, but for the exam purpose, you have to say the erythromycin. So alternative intravenous metoclopramide or combination with metoclopramide or erythromycin can be used in a prokinetic therapy. Now, next recommendation is critically ill, mechanically ventilated patient. Expected energy should be determined by using indirect calorimetry, but indirect calorimetry is not always possible. If calorimetry is not available, using oxygen consumption from pulmonary artery catheter or carbon dioxide production derived from ventilator will have a better evaluation for predictive equation. But remember, this thing is little bit it is cumbersome. So you can use this simple energy calculator is 25 to 30 kilocalorie, and you can use as a hypocaloric 70% initial stage, then you can increase. So next, during critical illness, now how much protein you will give, because this question come how much protein in a different scenario. Okay. So first, in critical illness, the protein requirement is 1.3 gram per kg protein equivalent per day can be delivered progressively. And the glucose or carbohydrate in ICU patients should not exceed 5 milligram per kg per minute. And regarding protein, you have to know the nitrogen balance. Anybody can say what is nitrogen balance? So nitrogen balance basically is a total protein intake by 6.25 minus your 1 plus 4 gram. That is the nitrogen balance. But usually we don't do in regular practice.